Acute ischemic stroke occurs when the cerebral blood flow falls below the level required for neuronal metabolism, most commonly due to arterial occlusion by thrombus or embolus. Normal cerebral blood flow is 50 to 60 ml per 100 grams per minute. When an artery gets occluded, as long as the blood flow is more than 20 millimeter per 100 grams per minute, the neurons function normally. When the blood flow falls below 20, when it is above 10 ml, there is electrical failure in the neurons, but the structural integrity is preserved. This region with 10 to 20 ml blood flow per 100 gram per minute is called the penumbra. It's a potentially salvageable tissue. When the blood flow falls below 10 ml per 100 grams per minute, there is rapid irreversible injury of neurons, and this region is called as the infarct core. So in the infarct core, the cerebral blood flow is less than 10 ml per 100 gram per minute, and there is rapid neuronal death within minutes, and it is irreversible. In the ischemic penumbra, the blood flow is between 10 to 20 ml per 100 grams per minute. The membranes are partially depolarized and is potentially reversible. All the goal in stroke treatment is to preserve this tissue, which is the ischemic penumbra. So, the timeline in the ischemic cascade, within minutes there is energy failure and depolarization. Within 30 to 60 minutes, there is cytotoxic edema. Within hours, there is excitotoxic injury to the neurons. And in 6 to 24 hours, there is inflammation and blood-brain barrier breakdown. So the goal of treating acute ischemic stroke is to save the penumbra, number one, and to intervene earlier in the ischemic cascade. The decision making in acute ischemic stroke has been evolving over the last 2 decades. To make an optimal decision, we need to know the duration since stroke onset, most importantly, and we need to know the severity of deficit as quantified by the NIH stroke score. And other tools in our use are CT brain, CT angiogram, CT perfusion and MR imaging, which help us to decide the time window versus the tissue window. The decision making in acute ischemic stroke has moved on from time window to tissue window in the recent years, and in the subsequent slides we'll learn how to assess this tissue window. So this is a brief introduction to the NIH score. The NIH score is a detailed clinical score to assess the severity of clinical disturbance, and the various domains assessed are levels of consciousness, gaze, visual fields, arm and leg strength, sensory examination, language examination, and neglect. This takes about 5 minutes to administer, and it is also available as apps in mobile phones for PG students to quickly use. So when the NIH stroke score is less than 4, it is called as a mild stroke. When the NIH stroke score is more than 20, it is a severe stroke. The most benefit of revascularization is seen in the moderate stroke, which is NIH score between 4 to 20. Coming to the plain CT scan, there is something called aspect score. This is basically dividing the MCA territory into 10 parts, and the total score is 10. When the total score is 10, the CT scan is normal. When the score is less than 7, the score is said to be severe. So the important question to answer in any stroke is whether it is a large vessel occlusion or not. The gold standard for diagnosing a large vessel occlusion is a CT angiogram. Clinically, if NIH stroke score is more than 10, it's likely to be a large vessel occlusion. Occlusion of ICA, M1 segment of MCA, basilar artery, vertebral artery, and A1 segment of ACA are called as large vessel occlusion. Next is perfusion imaging. Perfusion imaging can tell us in a clear-cut manner what is the volume of the core, what is the volume of the hypoperfused area of the penumbra, and what is the normal area. And there's also a parameter called Tmax or delayed contrast arrival, which also gives us the volume of the penumbra. So briefly coming to the eligibility criteria for thrombolysis, the clinical diagnosis should be stroke. The NIH score should be a moderate stroke between 4 to 20, and the duration should be less than 4.5 hours, and BP should be less than 180 by 110, or it should be controlled and brought below 180 110. The CT brain should not show any evidence of bleed, and there should be no contraindications. So this algorithm shows that in suspected acute stroke, rapid assessment and brain imaging should be done. And first we answer the question whether the patient is eligible for IV thrombolysis. If the patient is eligible for IV thrombolysis, we straight away go and thrombolyze the patient. If the answer to the question is no, then we reevaluate the patient whether he is eligible for endovascular therapy or not. If he is eligible for endovascular therapy, then we will proceed with the endovascular therapy. If not, supportive care will be initiated. The commonly used drugs in IV thrombolysis are altiplase and tenecteplase. Altiplase is a very short-acting drug, so it's given as a bolus followed by an infusion. Tenecteplase is a genetically modified variant which is a little longer acting. The mechanism of action is the same and it has greater fibrin specificity. Another advantage is that it's given as a single IV bolus instead of an infusion. So, most of the ongoing research in stroke is about extending the time window for stroke. To extend the time window, we have to quantify the size of salvageable brain tissue. There are various methods of doing that. Three of the important methods of quantifying the size of salvageable brain tissue are assessing the diffusion flare mismatch in plain MRI, assessing the clinico-radiological correlation, and then comes perfusion imaging. So first is diffusion flare mismatch. When the infarct is seen in diffusion weighted images, but it is not seen in flare images, that means the duration is less than 4.5 hours. So this is the most basic method of assessing the tissue window based on imaging. Coming to extended thrombolysis, a meta-analysis of pooled data from several trials have shown benefit of thrombolysis in 4.5 to 9 hours in properly selected patients. So we see that patient selection is very important in any thrombolysis or revascularization decision beyond 4.5 hours. Less than 4.5 hours, it's pretty straightforward, but beyond 4.5 hours, you have to go through a process. And parallelly, technology has also developed for mechanical revascularization. So we'll look at how to evaluate the patient for revascularization in this context. There are two main trials which revolutionized the concept of assessing the patient for revascularization. One is the DAWN trial, which was published in late 2017, and the other one is the Diffuse 3 trial, which was published in early 2018. The DAWN trial is based on the concept that if the patient has high clinical deficit and a small infarct core, that means he has a high volume of penumbra. Basically, this means the severe deficit is due to a large penumbra. The severity of deficit is assessed by the NIH stroke score, and the infarct core is assessed by the diffusion weighted imaging. Perfusion imaging was not compulsory in this trial. The DAWN criteria are the patient has to have a large vessel occlusion. The NIH stroke score has to be more than 10. That means the clinical severity should be there. and the window was 6 to 24 hours. For patients more than 80 years of age, the NIH score more than 20, the volume they took was, core volume they took was less than 21 ml. And in patients less than 80 years of age, again the NIH score greater than 10, the core volume they considered was less than 31 ml. And in patients less than 80 years of age with more severity, NIH stroke score more than 20, they considered a core volume of 31 to 51 ml. All these core volumes are very small actually. So the down criteria is meant for patients with a small core with a high deficit. So the next one is the diffuse 3 trial. There they picked up patients with NIH stroke score more than 6, large vessel occlusion, and 6 to 16 hours time window. In this trial, they took patients with slightly larger score. In down criteria, we saw that they considered very small cores, less than 21 ml, 31 ml, and 51 ml. In diffuse 3 trial, they considered patients with slightly larger core, that is less than 70 ml. And they mainly relied on two mismatch criteria, which are perfusion by core mismatch ratio, which should be more than 1.8. And the next one is mismatch volume, which should be more than 15 ml. So the diffuse 3 criteria mainly relied on perfusion imaging. So we'll consider some example case vignettes to illustrate how these down criteria and diffuse 3 criteria are applied in the real world. The first example, there's a 62-year-old male. Time since onset was 10 hours back. NIH stroke score was 14. That means severe stroke, more than 10. Deficit was right hemiplegia plus aphasia. Imaging CT angiogram showed left M1 occlusion. CT perfusion showed a core of 25 ml and hyperperfusion by penumbra of 70 ml. So we see that there is a good mismatch. Coming to the calculations, mismatch volume is 45 ml, which is more than the required 15 ml. Mismatch ratio is 2.8, which is more than the required 1.8. And the core is 25 ml, which is quite small. So the verdict is that it satisfies diffuse 3 criteria. This patient can be taken for thrombectomy. So the next example, there's a 78-year-old female presents with wake-up stroke. Approximate duration is 12 to 14 hours. NIH stroke score is 18, which is quite severe clinically. CT angiogram shows a right IC occlusion. DWI core volume is 18 ml. This is quite small. So this is high deficit with a small core. There is clinical radiological mismatch. So this patient satisfied down criteria and can be taken for revascularization. The third one is a 55-year-old male who was last well seen 18 hours ago, which is a pretty long time. And NIH stroke score was 16. And imaging wise, CT angio showed left M1 occlusion. Core volume was 21 ml and penumbra volume was 85 ml. And as we can see, the mismatch is huge here, even though the presentation was late. Mismatch ratio was 4.25 ml, which is very high. Mismatch volume also shows an excellent mismatch. So the verdict is that this patient is probably a slow processor with good collaterals and he satisfies diffuse 3 criteria and is eligible for revascularization. Coming to example 4, it's a 68-year-old female, 9 hours since onset. NIH stroke score is 15. The deficit is severe. CT angio shows M1 occlusion. CT perfusion shows a large core, 90 ml. And Tmax is also large, 120 ml. So the mismatch ratio is also small, mismatch volume is also small, core is very large. So the verdict is that the core is very large and mismatch ratio is small. So the risk is high and the benefit is low. This patient is not eligible for revascularization. Some real world cases may come only with CT scan. 58-year-old male comes in 11 hours. NIH stroke score is 17, which is a high deficit. And non-contrast CT brain shows aspect score of